Welcome to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, and I am so glad to be back in the Sunflower House for a new edition of a podcast on everything you wanted to know about peripheral neuropathy. And I am so happy to be welcoming an incredibly special guest joining us. He's Dr. John Morren, and we're going to talk about peripheral neuropathy. And hopefully we're going to touch on also an area that he's got a lot of expertise and interest in, the exciting topic of AI, artificial intelligence in medicine. But first, let me tell our listeners a little bit about Dr. John Morren. He is the program director of the Neuromuscular Medicine Fellowship at the Cleveland Clinic, and he was just named the director of the Neuromuscular Center at the Cleveland Clinic. He is an associate professor of neurology at Cleveland Clinic Lerner College of Medicine at Case Western Reserve University. His journey into the field of medicine began at the University of the West Indies for his medical education. And then he went on to do an internship and residency at Cleveland Clinic in sunny Florida. But then he came to Cleveland to do a fellowship here at the Cleveland Clinic in Cleveland, Ohio. And he is board certified in electrodiagnostic medicine, neuromuscular medicine, and neurology. So he's a bit of an overachiever. I'm sure his mother's very proud of him. Welcome, Dr. Morren. We're so thrilled to have you on our podcast.
Well, I'm thrilled to be here. Thank you for having me.
So I would like to start off by asking you about and explaining to our listeners, what is peripheral neuropathy?
So, peripheral neuropathy could be defined by the two labels in the name. So, peripheral, the far-flung areas are affected first. And what's happening? Nerve damage. That's what neuropathy means. So, for neurologists, most folks would say, hey, if you're a neurologist, you're a brain specialist, right? And it's true. The brain is the center of my universe, but it's not everything in the nervous system. The brain needs these wires, these nerves to do its bidding. So in peripheral neuropathy, these very important wires, they start getting injured and the damage starts happening at the far-flung areas. So think about your feet. Your feet are kind of the farthest part of your body from your brain. So those nerves, by the time the nerves travel all the way to your feet, they're very thin. And when they're thin, they're vulnerable. So if you have any type of nerve damaging culprit roaming about your body, the first nerves they're going to go after will be those vulnerable nerves in your feet. So patients usually start with feet symptoms.
And now, how common is peripheral neuropathy?
It is actually quite prevalent. Think about it. That's 1 in 11 Americans would have peripheral neuropathy. As we get older, just above the age of 30, it increases in prevalence about 1 in 10. So that's about 20 to 30 million Americans with peripheral neuropathy out there.
Wow. And so some of the more common causes of peripheral neuropathy and things that people can be aware of to maybe try to prevent problems.
Yeah, probably not too surprisingly, diabetes, and not just diabetes, the metabolic syndrome. That metabolic stew that usually occurs with diabetes, not just the high blood sugar, but the cholesterol and the triglyceride increases, the obesity and overweight status. That combination, what's called the metabolic syndrome, is actually the driver for neuropathy in over 50% of cases. And by the way, if you have diabetes, 50% of patients with diabetes will eventually develop some form of peripheral neuropathy. So that's why it's the leading cause. Other common causes would be nutritional, especially in patients who have malabsorption. And there's a lot of weight loss surgery now, and that's a big risk factor. And there are a lot of medications that promote rapid weight loss, and that contributes as well. The other major culprit would be so-called toxic causes, and that includes excessive alcohol use, and even excessive vitamins like vitamin B6. And this is important.
Yes.
I try to evangelize this. People think vitamins are a good thing. So, if you take a lot of a good thing, it should be very good. And that's okay with many micronutrients, but certain ones are actually harmful to nerves, including vitamin B6 or pyridoxine. So this is something, we've done a lot of advocacy around. Another category of contributors would be autoimmune conditions, especially conditions like Sjogren's syndrome and lupus.
Yes. And I think that's really important. I know years ago, B6 used to be used in super high doses to treat PMS or mood symptoms. And a lot of people think that just because something's over the counter, that it's safe and effective and they can take whatever dose. And I mean, I just see people on so many supplements, and sometimes they don't even know why they're on them. And things that aren't food or drugs don't have to be regulated by the FDA. And so I always wonder about contamination. Um, so, can you tell us about some of the symptoms of peripheral neuropathy?
Sure. So I tell folks, nerves they kind of belong to two major species. The nerves that cause us to generate force or strength or power. So that's the motor nerves. And the nerves that allow us to feel things, the sensory nerves. So when you get nerve damage in peripheral neuropathy, you get symptoms that are both motor and sensory. Quite often, the sensory symptoms start up first. So typically, a patient would come in the office and say, Doc, this started with numbness and tingling in my toes and feet, and over time it moved up, and now it's at the level of my knees, and I'm now feeling it in my hands, all fingers. And that's a typical so-called length-dependent pattern of these symptoms, typically numbness and tingling being the initial ones. And later on, you'll have motor symptoms, and that might be gait unsteadiness, or problems walking and balance, and eventually getting into stumbles and falls. And sometimes you end up with foot drop on both sides. The important thing, though, is that these symptoms tend to be a mirror image going on the other side. So it's not one-sided, it's what we call symmetrical. And that's a key feature of peripheral neuropathy.
Now, can you tell us, are there any gender differentiation? Are women more at risk than, say, men for peripheral neuropathy?
So to date, majority of studies show that there's no major susceptibility of women versus men. So those differences aren't traditionally appreciated. However, we're getting newer data that suggests actually there might be some skew towards women for certain drivers of peripheral neuropathy, like autoimmune conditions, especially Sjogren's disease and lupus.
Yes.
Autoimmune conditions, as you know, are 4 times prevalent in women versus men, so that's a major driver. And some recent studies are also pointing to women with diabetes. So if you have a patient with diabetes and that patient is a woman, she would have a higher chance of having more of the painful diabetic neuropathy category of disease, which means then we need to be particularly attentive to our patients with diabetes who are women to screen and to ask those questions. As you know, women tend to actually bear pain a little bit better than men. I'll say that, and I see that a lot in my practice, including the testing I do that could be uncomfortable at times. So it's something we should be a little bit more vigilant about.
That is interesting how people have different pain thresholds and the perception, of pain, and everyone is kind of wired individually. I remember my son when he was interning with one of our dermatologist who was doing Mohs surgery on a husband and wife team, the exact same skin cancer, and they would shift from room to room because they do it one layer at a time. And he was so impressed with how much the man seemed to feel more pain than the female. But it certainly is individual. And diabetes and diabesity and the metabolic syndrome is something I just keep seeing increasing amounts, and it's really very concerning. Can you talk about some of the other risk factors besides elevated sugar and alcohol for other types or risk factors for causing peripheral neuropathy?
Sure. As we age, we tend to see an increased prevalence, as I'd mentioned before, and that probably is linked to the fact that as we get older, we tend to have a higher risk for, some of these chronic illnesses, which are vascular risk factors, as you call it, diabetes or metabolic syndrome. Um, Another one that I kind of hinted to is rapid weight loss, especially in the context of weight loss surgery, because malabsorption of these important nerve supporting micronutrients could be at play. Certain occupations, heavy metals like lead and mercury can can lead to peripheral neuropathy. And if you're in occupations where you have those exposures, it will be something to consider. There are infectious causes of peripheral neuropathy like HIV, and even HIV medications. Some of them have a high propensity to cause peripheral neuropathy. I can't leave out chemotherapy. A whole host of different chemotherapeutic agents have peripheral neuropathy as a very frequent adverse effect. And some of the worst peripheral neuropathy I've seen occurs in the wake of certain chemotherapies, especially those based on Taxol compounds and platinum.
And certainly, we have a lot of breast cancer survivors in our practice at the Center for Specialized Women's Health at the Cleveland Clinic. And I know those symptoms can be so annoying. Sometimes they do seem to get better, but other times they don't. And I've been struck with, despite the fact we have overnutrition in terms of calories with so much weight and sugar and diabetes problems, we still have so many vitamin deficiencies. And you were mentioning some of the B complex vitamins, particularly thiamine B1,
Yeah.
which on our speakingofwomenshealth.com website, we have a list of foods rich in thiamine. And B12.
Yes.
And I used to routinely check for B12 deficiency in pretty much everybody over 65, or if they were like a strict lacto-ovo vegetarian without
Yes.
milk or eggs or meat.
Mhm.
But then I started doing 60, now 55, now I'm down to 50. I am shocked at the number of women in my practice that I find who have B12 levels under 300, which
Yeah.
some of the lab ranges say that's okay, but I've heard neurologists say that really they want your level way over 300. And I wondered if you had comments on B12 or that vitamin in particular.
Yeah, that's a very important point. B12 deficiency is a major driver for peripheral neuropathy, and it's one of those treatable ones. It's one if we could prevent, it's great, and if we catch it early, we can actually make the biggest difference in changing the trajectory of somebody's nerve health in the future. Um, yes, there are patients, they may have malabsorption syndrome. As you know, there's an autoimmune variety, pernicious anemia that sets you up for having severe B12 deficiency. But there are many patients we don't quite know why. To your point, they don't have restrictive diets and things like that. So it's worth screening. Yes, us neurologists, we like to see that level above 400, although the reference range will have it like somewhere about 230 or 250. Um, and because we do see this relative B12 deficiency still causing neurological complications, including peripheral neuropathy. And for those who are providers in the audience, I add a methylmalonic acid level.
Yes.
Quite
Hmm.
often, you might have normal vitamin B12 levels, and the MMA, methylmalonic acid level being elevated will expose B12 deficiency in an additional 10% of patients. So we like treatable things, and that's a low-hanging fruit, and it's one well working up to uncover if it's there.
Now, in terms of evaluating for like toxic exposures, do you do like blood level panels for lead, heavy metals? I know some of the functional medicine people cut the hair and assess for heavy metals in the hair. I just wonder how you go about assessing that, or you only do it if you think the person has an occupational exposure, but how do you know someone in their household's not poisoning them? I always wonder about these things.
Yeah, yeah, these are fair questions. Thankfully, peripheral neuropathy from heavy metal poisons is very rare. And depending on the particular agent, and you could, a good history and knowing the particular occupation, the exposures will inform which one of these heavy metals you may want to look at. And to your point, depending on the particular agent, you may need to do urine screen plus blood screen plus hair and nails. And I think, this probably beyond the scope of our podcast today to get into that. But whenever you suspect it, though, and you feel that you may need help, reach out. A neuromuscular provider will probably be your friend to help you navigate that if you're a provider working up a patient with this. Obviously, a medical toxicologist is there for you too if we're dealing with something that is not garden variety.
And when you're dealing with a patient that has peripheral neuropathy, um, obviously probably it's most commonly in people with elevated blood sugars as well as, alcohol use, which a lot of people minimize their alcohol use. And
Mhm.
we had a recent podcast going over alcohol problems and some of the specific issues in women. Um, when it's idiopathic and you've evaluated it, or even if it's diabetic or toxic related, is there any specific recommendation that you make for vitamins? Like, I know Metanix is FDA approved, which is methylated vitamins for those patients with diabetic neuropathy. Sometimes I have recommended that, just like I recommend a lot of Cerefolin, brain wellness, or NAC, methylated vitamins for the brain, with N-acetylcysteine for glutathione,
Mhm.
and alpha lipoic acid. I wondered if you had any comments about those supplements,
Yeah,
or any other supplements for
sure.
peripheral neuropathy.
Yeah, that's a really good point. You also mentioned idiopathic, and probably will be remiss if I didn't say about 30% of almost a third of patients with peripheral neuropathy, no matter how we look, we can find the culprit. And that's why it gets the label, idiopathic or cryptogenic peripheral neuropathy. And that, yeah, is a challenge in multiple ways, but no cure doesn't mean no care, right? We do what we can to treat symptoms and reduce burden of disease on patients. So when it comes to the so-called natural alternatives, so nutraceuticals, there's an emerging body of data that's showing that there are some signals to support their use. It's not overwhelming in many of the real rigorous studies. Among the nutraceuticals, though, alpha lipoic acid seems to take the lead in terms of objective data showing not only some symptomatic relief for things like tingling, burning, prickling, but also some neuroprotection and possibly nerve repair. So it's the one I often prescribe. Lots of my patients are on alpha lipoic acid. It's usually 600 milligrams by mouth once daily, but this dose can be adjusted based on individual profile. Some of the others I'm a little bit careful about. A lot of the you'll see there are a lot of products that combine alpha lipoic acid with numerous other antioxidants and micronutrients, including B6. And I see a lot of folks with elevated B6 levels, and the only source we can identify are these compounded supplements that basically fold in B6 with multiple other agents. So it's one we have to be careful about.
Very interesting. You have been listening to the Speaking of Women's Health podcast. I'm your host, Dr. Holly Thacker, the executive producer or executive director of Speaking of Women's Health. Lee Kleckar is our executive producer. She's so helpful. And I run our Center for Specialized Women's Health and our Women's Health Fellowship. And I am speaking to the head of our Neuromuscular Center and Fellowship, Dr. John Morren. We're talking all things peripheral neuropathy. The one interesting comment that I have to make as a menopause specialist, someone who's studied the ovary and estrogen deficiency, and someone who has really enjoyed getting a lot of neurologic or consultations from my neurology colleagues in women with neurologic problems, is it certainly seems like estrogen loss makes the peripheral nerves more irritated. And some women can even have unusual symptoms that we call formication, which is tactile hallucinations. They feel like things are crawling on their scalp, or they can't stand for anyone to touch them, and they're more irritable. And certainly any neurologic condition in the brain or peripherally seems to get worse when a woman loses estrogen, which is why I've over my practice got to see so many interesting women with multiple sclerosis and myasthenia gravis and Parkinson's and so on. So I think that's kind of important to optimize estrogen. And obviously, women become estrogen deficient consistently at midlife if they're not treated, whereas males don't because they make testosterone, which gets converted to estrogen, and that's why they have less osteoporosis. That's why I was wondering if there was any sex differential, if their peripheral nerves are less likely to get irritated at all, or have less likely to have those kind of peripheral neuropathy symptoms.
I think it's an active area of research. We don't have any hard data to kind of to say that exactly happens the way we anticipated based on the hypothesis. But I suspect, though, that just like you said, I do see postmenopausal women who come with some of these more diffuse symptoms. And if they're what we call centrally sensitized, and you're kind of implying this, that any nervous system disturbance, especially if it involves the sensory pathway, it kind of gets amplified. Um, and the symptoms run the gamut. I know I just said numbness and tingling, but I hear words like burning, prickling, bugs crawling, electrical zap-like sensation, sunburn feeling, sizzling. These are, words for my patients, and that's frustrating sometimes for patients to express. Like, I don't know how to tell you, doc, but it just doesn't feel right. So I empathize with them, and thankfully there are medications that can help alleviate the burden of symptoms, and we can talk about those. So we are able to help.
And so, talk to us about some of the treatment options from at home treatments to medication to physical therapy or other assistive activities.
Right. So you know, the treatment for symptoms kind of starts with an assessment of symptoms burden. I don't think um, we necessarily will put patients on medications unless we believe that the benefits are going to outweigh the risks. So I like to tell patients less is more, believe it or not. I believe that. I'm not here to just add to your polypharmacy or add to your long medication list. So sometimes, for example, if symptoms are fairly mild, we don't need to do much, or we could start something natural. And although alpha lipoic acid may take the pain score a couple notches on a pain scale, that might be sufficient for somebody in fairly mild and limited symptoms. Even topicals are there. We could use lidocaine gel, capsaicin cream, and again avoid systemic adverse effects as we do that and not take a pill or something like that. So, but when it comes to more robust symptoms that hamper quality of life, and unfortunately a lot of neuropathic symptoms get worse at nighttime, which means it can disturb sleep. And if it disturbs sleep, then you have more daytime fatigue, and it becomes a snowballing effect. So adequate treatment of neuropathic symptoms is a very important upstream move. So we have medications that reduce things like tingling, burning, prickling, and some examples would be like gabapentin, pregabalin, duloxetine, and there's a whole host of these. So we could unleash that. So those are some of your pharmacological approaches. There are non-pharmacological approaches as well. From things like TENS units, people who got acupuncture. Thankfully, we don't have to use this very often, but for very severe and refractory cases, even spinal cord stimulator implantation is an option. Um, Unfortunately, we don't have medications or therapies that address numbness. Some patients, sometimes they don't have a lot of painful symptoms, but they have numbness, and that one has been a little bit more difficult to address with medications or other forms of therapy. Alpha lipoic acid has shown some help with that in some limited case series, and so the evidence there is evolving. Now, motor symptoms, things like imbalance, and again, if peripheral neuropathy is advanced, we are talking about significant fall risk. That becomes important to manage as well. By this time, you're at risk for having tissue breakdown and things like that in your feet. So inspecting your feet, getting comfortable shoes, well-cushioned shoes, good arch support, having a podiatrist on your side is going to be important. Physical therapy, obviously, for retraining gait and improving balance and preventing falls, getting the right braces when you have like foot drop, and these things are all part of the wider picture of treatment.
Now, talking about medications, I was recently coming across a report that looked at a large series of patients that was noting perhaps a higher risk of cognitive decline in those on gabapentin, brand name Neurontin. And I wondered, do you think it's dose related? Is it age related? Is it too soon to say? Do you generalize that to all the pain anticonvulsant medicines, including pregabalin, Lyrica?
Yeah, I think, interestingly, a fair amount of patients have brought this up because I guess, these studies are making its way through, mainstream media. And, one of the commoner adverse effects of gabapentin and similar medications is this, you could call it cognitive blunting, we could call it brain fog and things like that, because um, indeed, these were initially anticonvulsants, so they were meant to make nerves less excitable. Um, so again, less is more. If we could get away from these, we do. But by and large, I do believe that with my vast experience, including many colleagues who prescribe these medications to many of our patients over many years, the vast majority of patients do well cognitively. So it's certainly one of those situations where you have to individualize the care. If I see a patient already has significant risk factors for cognitive decline, probably not the medication I would choose. And I would say I could leave the vast majority of patients on their cognitive A game by using these medications judiciously. There's a way to minimize the dosing. There's a way to time the dosing and stuff so that you would minimize the cognitive blunting adverse effect.
That's all very interesting. We use a lot of off-label gabapentin to treat vasomotor symptoms. And of course, in the history of menopause field, women used to be given barbiturates to drug them basically for having symptoms. And now we have a lot more elegant, specific candy neuron inhibitors that, affect the part of the hypothalamus that is involved in temperature stimulation. So luckily we have more specific options. And of course, hormone therapy for most women is generally an option. So I'm always interested in these class of medications and also in giving people relief because obviously chronic pain can be very, very draining.
Yeah,
Getting back to the alpha lipoic acid, on our website, Speaking of Women's Health, we have a list of foods that have alpha lipoic acid in them. But when you're using it for neuropathy, you're using it in much higher doses than what you would get nutrient-wise, right?
correct.
Yeah. And certainly a lot of medications like we know that can affect B12 levels that we were talking about earlier, like metformin glucophage to treat diabetes can
Yes,
lower B12 and the PPIs for stomach acid blockers
yes.
that, people are on, that is always a trigger for me to check B12 rather than to wait till they have neurologic problems. I wondered if there's any other classes of medicine that as a neurologist that specializes in neuromuscular disease, does it ring bells like, oh, this could be a risk factor or this could affect something in the patient's profile?
Well, when it comes to B12 itself, there are certain Parkinson medication labeled upacarbidol, especially if it's delivered. There's a duodenal administrative form of the medication that has also been associated with B12 deficiency. Um, Medications that are some antibiotic classes, like even nitrofurantoin, can can be seen to cause uh, peripheral neuropathy as well. I will say though the big classes that we mentioned are the foremost. If you look long, far down enough, many medication adverse effects lists that are put out there, you would see numbness and tingling. So I don't want to create a great phobia around some of these tried and true medications been around for a while. But I would say certain antibiotics can be associated with peripheral neuropathy. If you're on chronic long-term antibiotic, I think it might be something you want to highlight to your neurologist because you might want to see if there's a more nerve-friendly alternative if you're on one of those that are known to cause. Um,
That's an excellent tip, and we just had a post podcast on preventing bladder infections, chronic UTIs, and nitrofurantoin is given to a lot of women to take, post-coitally to reduce bladder infections, and that's when you can use local vaginal estrogen to prevent UTIs in a lot of women. That might be a better choice. And obviously antibiotics, like I remember in my inpatient days, gentamicin affecting, the
yeah,
inner ear and the eighth cranial nerve is so sensitive.
mhm.
Um, so this has been so great. We'll have to bring you back, but before we go, just a little teaser about um, artificial intelligence. If you can tell us a little bit about that and how you think that will play into medical care, patients' lives, our lives.
Yeah, it's a very exciting time to be alive, certainly in healthcare as well. And I know, it's this brings a lot of dread for some. And even for those who are adopters or who are open-minded, there is a healthy fear. And I think we need to have a healthy fear about AI in medicine. This is a high stakes environment, and but what I advocate for is really the responsible and equitable judicious use of AI in medicine. And I will say that as great as the AI technologies are evolving, they will not replace human beings. I really believe the appropriate place for AI is in conjunction with human intelligence. And when I say AI, I actually say augmented intelligence, because a human in the loop is the important part of what makes AI augmented intelligence. And I say, artificial intelligence plus human intelligence equals augmented intelligence. And this is an equation of not additive benefit, but synergy. So what it allows us to do, we have to admit, as much as we are trying to improve the talent pipeline in healthcare, we need to extend ourselves and provide care to more patients, to improve access, to triage better, to pick up certain conditions much earlier than we're picking them up. This exceeds our ability to do with the human resources we have, and AI allows us to be extended in certain ways. And I see it as allowing for hyper personalization of medicine. For example, it's not going to be too far down the road where we will be having certain embedded AI technologies in a primary care office that will let a primary care doc who has to keep so many things in mind and do so many things, and you're feverishly trying to get things done efficiently. It might be difficult for you to remember, oh, this patient actually has a very high risk of peripheral neuropathy. So this could be flagged, and based on certain unique features demographically, comorbid profile-wise, blood results-wise, the provider would be told this patient needs to be screened. Remember, when you examine, just check that pinprick sensation in the feet or monofilament test or whatever. And in a busy practice, that will be very helpful. My personal work at the clinic involves using AI in electrodiagnostic technology. We didn't really talk about how you make the diagnosis. Yes, history and exam, very important.
Yes.
Blood tests for finding underlying causes in the conditions that we talked about, but electrodiagnostic testing, commonly called EMG and nerve conduction studies. And these tests are kind of the core foundational objective way of figuring out what stage neuropathy is, mild, moderate, or severe, how active it is. It might actually hint what's driving it. But these technologies are also optimized with certain AI tools embedded in them, and that's what we're working on. So we can make the diagnosis even before patients complain of the classic symptoms, and probably inform how we manage them based on certain things we can't see with the human eye or even hear with the human ear, because this is an audiovisual test. So it's an exciting time, as I mentioned, but it really requires a human in the loop, and that's what I would say. And I don't think we're going to be replaced. I say, AI will not replace human providers, but human providers who leverage AI will likely replace those who do not.
Well, that's a good way to sum it up. So, how can our listeners who live in the Northeast Ohio area or would travel here make an appointment with you or follow your work or any social media or anything we should get out to our listeners?
Well, I would say my appointment line 216-636-5860 would be the way to do it by phone. Most of my patients, they're very internet savvy. So once you jump on an internet search, you will be able to land on our homepage, and it'll be easy, of course, to request an appointment, set that up with myself, one of my colleagues here at the Neuromuscular Center, and we're always happy to make a difference in patients who we've seen so many patients in their journey, and what drives me to do what I do every day and come to work is to make those differences in the lives of patients. Peripheral neuropathy is one of many things we see here. There's a whole host of other neuromuscular disorders. So I'd encourage the listeners to go to our website, the Neuromuscular Center at Cleveland Clinic, and you know, the appointment line is something that allows you to get on very easily. If you have an account with the Cleveland Clinic, a MyChart account, setting up the appointments through MyChart is what most of my patients do as well. So I encourage you to do that.
Well, thank you so much, Dr. Morren, for joining us. If you've enjoyed this podcast, please give us a 5-star rating. Share it. You can like us on YouTube, on Rumble, and if you don't already subscribe to our podcast, you can follow, collect, or listen to us regularly, all for free. So remember, be strong, be healthy, and be in charge.